So we're going to first talk about injury recall technique, which has to do with the history of injury and trauma. And if you have the QA book, it's page 4A. Now, this technique, I call injury recall technique, was developed by a podiatrist, Robert Crotty, DPM. He's deceased now. He's from Okmulgee, Oklahoma. And Gordon Bronston, who's a podiatrist in Lathrop Village, Michigan, who has just retired within the last year. And I'll talk a little bit more about this in a minute, or a little later on today maybe. But Gordon Bronston, when I was in practice for the first 5 years in Dr. Goodhart's office in Detroit, Gordon Bronston was practicing podiatry in one of the Detroit suburbs, and we were downtown. We had patients from all over southeastern Michigan, really. And I have these patients come in periodically and say to me, "You ought to meet this guy, Dr. Bronston." And then another one would come in and say, "You ought to meet this guy, Dr. Bronston. He's a lot like you." "This guy, Gordon Bronston, he's a lot like me." "Why is he a lot like me?" And he says, "Because he does really weird stuff, but it really helps a lot." So he's actually kind of short, and I'm kind of tall, and he's kind of thin, and I'm kind of wide. And so anyway, but Gordon was doing the technique of Dr. Crotty and became the major innovator following Dr. Crotty's retirement. And Dr. Bronston just recently retired. And I went to see him one day in April, after having a foot injury, playing touch football in October, the October before, in like 1987 or something like that. I had made a cut going out for a pass, stepped in a hole and tore my plantar fascia. And it was so bad I was on crutches for a day and a half or so. And then I finally got treated and it got better, but it was still, for months and months and months, it was aching so bad. At the end of the day, I would be taking my shoes off because it would give me some relief. Just throbbing, aching, deep kind of pain that would get worse as the day went on, and nobody could do anything to fix it. So in the meantime, way back in the late 70s when I was in Dr. Goodhart's office, Gordon Bronston, I finally met him. He came to one of the seminars that Dr. Goodhart and I taught, and we then exchanged patients. And I had pretty much everyone in my family go see him as a patient. Everyone had seen him but me. My grandparents had seen him, my parents had seen him, my sister had seen him, and everybody, brothers had seen him, everybody had seen him, but I had never been a patient of his. So finally when I got this foot injury, it's like, you know, if you don't have a foot problem, why go see a podiatrist? If you don't have a spine problem, why go see a chiropractor? You know, it's the same kind of mentality that I had. Kind of kicked myself later about it, but I finally hurt my foot, so I said, well, I'll go see a podiatrist. You know, I'll go see him. So it was April after October, and when I went in to see him, he took a history, and he started working with me, and he pushed on the plantar fascia. It was so tender. He says, "It hurt right there?" I said, "Yeah, right there." And he went boom, boom, boom. Within 6 seconds, and I'm not kidding you, within 6 seconds, he pushed there again. He says, "How is it now?" And the pain was gone. It's like 90% gone. It's like, whoa, I've had this pain for months. And he did a couple more things, it was 100% gone. It was like with less than 10 seconds, like 5 or 6 seconds. And I said, "I got to know what this is." He says, "I'm too busy to tell you, I got other patients." Now, at that time, I was living in North Carolina, and I was coming up once a month to teach with Dr. Goodhart in Detroit. Some of you have taken some of those courses with us. We used to teach in Detroit regularly once a month for many years. And so he said, I said, "I'm coming up next month." He said, "You need to follow up on this." I said, "Can I come back next month?" He said, "Yeah." He said, "Make yourself the last patient of the day on Friday when you come up, and I'll try to talk to you a little bit more." So he came up to me. I came up to see him the next month, and he came up in the treatment room, and he worked on me, and the pain was like, you know, virtually still all gone, 98% gone or something, and he fixed what last little bit was. And I said, "I've got to tell you, this is remarkable. I've had all the best people I know in North Carolina work on it, and my proteges and everybody, and you know, you took it out, pain out in seconds, and I'm very impressed." And I said, "What are you doing?" Now, he tried to explain it to me, and what he did explain to me is what I'm going to tell you later on when we talk about something called injury recall technique for the rest of the body. What he said to me at that point, in conjunction with explaining what the technique he was doing, which was something he was doing to my foot, because he's a podiatrist, right? He said, "Wally," he said, "the single most important item in the history of a patient is their history of trauma and injury." Let me say it again. The single most important factor in the history of a patient is their history of injury and trauma. Now, someone's going to come along and say, "Oh, I would disagree. I think it's their genetics." Or someone's going to say, "No, I think it's their emotional history." Oh, I can make a case for all that, but you could make a case for what Gordon said. the single most important factor in the history of the patient is their history of trauma and injury. And the reason is because there's a muscle reaction. It's obviously a neuromuscular reaction. A neuromuscular reaction to the injury. We get an injury, step on a tack, we pull our foot away. We put our hand on a hot burner, we pull our arm away. But it's not just our arm that's pulling away, our whole body's getting into the action. It's not just stepping on a tack and pulling our foot away, our whole body gets into the action. And if the injury is bad enough such that it reacts in a period of time where the body starts adapting to the injury, then the body gets an adaptation to that injury, which I tell patients is a muscle memory of the injury. Now that's a sort of oversimplified explanation to say it's a muscle memory of the injury, but it's not inaccurate. The muscular pattern that happened at the time of the injury, put your hand on a hot burner, burn your hand real bad, pull away, in time your arm goes back to normal position, but there's still this tendency for the muscles to stay in that withdrawn reaction throughout the body. So an injury anywhere in the body can impact anywhere else in the body because usually we don't just pull the arm away, we pull the whole body away. And depending on the injury, if you're bending over like this and put your hand on a hot burner and pull away, as opposed to if you lean back on a hot burner and pull away, the starting point is different, so the muscle reactions are different. There is an adaptation which takes place to injury, and if your body holds on to that adaptation, you get this muscle reaction, which they call the muscle chain response. And there's one article published in podiatric journals, and it's called Muscle Chain Response, and it's in 1988 by Dr. Bronston. What you have to do is you have to bring the injury into the body's awareness. Now in chiropractic neurology, we would say you have to bring the neurons to threshold, bring the cells to threshold of firing. If they're not firing, you have to make them fire to remind the body what was happening at the time of injury. So if there's an injury to hand on a hot burner, you would maybe pinch the hand to activate nociceptors if you're the doctor, or you could just have the patient touch the hand. But in some way, you have to activate the area of the injury. And that brings those neurons in that pathway for that injury, it brings them to threshold or brings them up to firing level closer to where they could fire. And then what you have to do is you have to do something else. And the something else is a manipulation for the rest of the body of the talus, which is what the podiatrists figured out. For injuries from the head and neck, this something else is a manipulation of the atlanto-occipital area, and it's a flexion. And it's extremely simple, and it's extremely valuable. It's probably, if I could only do one technique on patients, and I was limited to doing one thing that I could do on patients, and I couldn't do anything else, and I want to get the most mileage from it, I would do injury recall technique. And you'll see why as we go along here in a minute. So, injury recall technique has got to do with the body remembering where its injuries were. So we're going to start off by talking about head and neck injuries. Anything above the head and neck. It could be dental, could be broken nose, could be hit in the head with a baseball bat, could be cervical, but anything from C7 up, let's say. And you can use the injury recall technique for the rest of the body, which is what the podiatrist taught me for anything in the head and neck, but I found it more convenient the way we treat patients to do this. I actually developed this piece of it, which I think actually I like to do a little better than what we'll talk about later. That's why I separated out. What happens, think what happens to yourself. You get hit in the nose, what do? What's your muscular reaction to hit in the nose? Right? You're sitting in a dental chair and they're drilling in there, it doesn't feel good. What are you doing? What do? Same extension, right? Somebody pokes you in the eye, what do? You extend. Well, all that stuff's coming from the front, but what happens if you you get a whiplash? There's extension with that involved usually. What if somebody comes from the side and hits your head? There's still a component of extension. Rarely do we ever withdraw from an injury in the flexion if it's injury of the head and neck. We always tend to do extension. There are the startle reflexes, like the Moro startle reflex and the Landau reflex, and these primitive reflexes that are built in it. There's also extension. These extension pathways are very powerful. And what happens when there's an injury to the head and neck, this reflex pathway, part of the flexor withdrawal reflex or the flexor reflex afferent response in neck and head injuries is actually a neck extension, like this. And it's a neck extension particularly, it appears, at the atlanto-occipital area. Now the whole neck may extend, but the key part is the atlanto-occipital area goes into extension. And so what happens is at the same time the injury occurs to the head and neck, the injury sends messages to the brain, and the extension response sends messages to the brain, and they get locked in there together. Kind of get locked in there together. And so what we find out as the patient walks around, if the injury heals, sometimes they still have this memory of the injury, this muscle memory of the injury, which is really a neuromuscular locking of these two things that fired at the same time, the injury and the neck extension. And what we have to do is we have to undo that. And the way to undo it is as simple as pie. You basically activate the area of the injury and put the head in flexion. You just sort of do the opposite at the time that happened. But you have to do two things at the same time. You have to bring both the threshold at the same time and reset them. So what I want to do is I want to demonstrate this to you several times. And what I'm going to ask